In this episode, we are speaking with Rebecca Love, who was named one of modern healthcare's most influential people in 2022. Rebecca is currently Chief Clinical Officer at IntelliCare, which is focused on workforce management solutions. She is also a nurse educator and experienced nurse executive. She has founded the Society of Nurse Scientists, Innovators, and Leaders, and also founded the well-known Nurse Hackathon, which has led transformational change in the nursing profession. And if that wasn't enough, this year, Rebecca co-founded the Commission for Nursing Reimbursement, working to respond to the nationwide nurse staffing crisis. Holy moly. Wow, Rebecca, you are such a busy lady. Welcome to the show.
Constance, thank you so much for having me. It's such an honor to be, and I'm just so excited to hear about everything that nurse informaticists are doing and continuing to do to shape the future of healthcare. So it's a real honor to be here. So thank you for having me.
We are so happy to have you, Rebecca. So there is so much that we could talk about in your career. What a lineup. But let's talk about your most recent venture in leading transformational change for nursing and the Commission for Nursing Reimbursement. So what is the history of nurse reimbursement or the lack of a reimbursement model for nurses?
Yes. So, well, thank you, Constance. And I think that the reality is we have to go back almost 100 years. And I actually had to hire an expert in the deep web to find these articles. It's been almost a year of research. It was the same expert that Johnson & Johnson hired when they made the Nurses Change Lives video, because so much of nursing history has been erased at large scale. So you had to find somebody who would be able to go into old archives, unpublished or stopped being published in books, things that have gone out of print. And so it took a long time, but let me step you back. About 100 years ago in the United States, in the early 1900s, women were fighting for the right to vote. And at that time, women had been fighting for the right to vote for nearly 60 years in the United States. The women's suffrage movement had gone on, and the American Nurses Organization at the time had not gotten involved in that fight. They had stayed outside of the fringe of that debate until 1913, in which the National Organization for Nurses decided to support the largest march for the women's suffrage movement in the history of the country. And it was the day prior to Woodrow Wilson's inauguration. So thousands of spectators witnessed the women's suffrage movement happening in 1913, and the movement took a life of its own. And in 1920, women in this country got the right to vote. But that was really the turning point for nurses to get involved in the women's rights movement. Women got the right to vote. And in the 1920s, nursing became the largest economic vehicle for women's financial independence in the history of the country. Nurses at that time all ran their own independent companies. They all had private duty families who hired them directly to deliver private duty nursing care. Now, at that time, hospitals were this place of deplorable conditions. Only the most destitute sought care there. The primary vehicle of care was actually delivered by physicians who practiced and billed independently for their services, and nurses who, again, also privately, independently billed and delivered nursing services privately. But as surgery got better, hospitals and families started to bring private duty nurses into the hospital. Hospitals started to see that care started to get better. They started to employ nurses directly into hospitals. Now, what you might be unaware of is actually in the 1920s, on every single hospital bill that existed, nurses actually had a billable service. On every hospital bill, it specifically read nursing services with a price point. Now, at that time, hospitals were run by men. Physicians were male. And what they started to feel was that nurses and women started to have too much power. As the historian Donna Deers expertly wrote, she said they wanted to create a model that would keep nurses as far away from the money as possible, because they started to feel nurses and women were too powerful in this model. So as 1930s came along and the discussions for a national insurance model just started to develop, physicians and hospital administrators looked for a model where they could quantify nursing value and skill set, but not call them out in the financial model. So they looked to hotels. They saw that maids were rolled into room rates, and they rolled nursing into room rates of hospitals, forever placing nurses on the cost side of structures. And actually, one of my colleagues, Wanda Montalva, put a post out that said, hence the term handmaiden came into existence for nurses. And you saw a significant portion of nurses leave the profession at that point in time. And what we have done in 100 years is that nurses are the only healthcare professional that has remained without a billable service, and are the squarely a cost to healthcare systems, which mean more nurses equal more cost without an associated revenue line, different than every other professional, OT, PT, respiratory therapy, MRI techs. More of them leads to more billable services. And we will constantly have this misalignment between the need for more nurses and the cost of nurses, which will mean healthcare systems will always staff nurses to the lowest cost denominator in all situations, not to what is safe and best for patient care and driving forward healthcare. So Constance, I know that was a long story, but it was very important to explain that why this model existed. It was actually based, in my opinion, in much of the sexist policies of the early 1900s that really tried to undermine the strength of women and the growing movement of economic independence that was being led by nurses, where the country valued and would pay for nursing services. But there was a conflict over that economic model because the males in the society did not want to recognize women's financial independence following the women's suffrage movement.
It's just amazing to me that we are still, we're in the same position that we were 100 years ago. And that I think that's what amazes me the most, is that we still apparently haven't really stood up for ourselves in all of that time. And there's so many movements along the way in those 100 years involving women specifically. Now, of course, men are with us as well in this profession, but it's just that we're still clawing and climbing our way into this. It's just amazing to me to hear this again. So I appreciate that history, and thank you so much for talking about that and giving us all the insight that you have. So to take this to the next level, then, you touched a little bit on why a reimbursement model would matter, but also to expand on that, how would it actually stabilize healthcare?
Absolutely. Now, and Constance, I think it's very important, and you said something very critical, which is, diving into all these pieces of history, largely that have gone unwritten, or when they were written, they were buried, right? There's been constant movements by nurses over the last 100 years to try to advance their causes, but nobody heard or saw them. And we were told that we should be doing this because we care about patients, right? It doesn't matter about the money, but the reality is what we've come to realize, it is all about the money in healthcare. And let me give you an example of why this matters. In a recent situation that occurred in North Carolina specifically, the Treasurer's Office pulled the Medicaid license from the state of Novant's, or the healthcare system Novant's healthcare license, because they said they had no more money to fund for nurses. So they had cut nursing staff, closed floors, and patients were waiting 24 hours in the emergency room, and patients were literally dying waiting for care. So the Treasurer's Office called them and wanted to know, what about all the billions of dollars that I've given your healthcare system the last few years? Why are you not delivering care? And as soon as he threatened to pull their Medicaid license, they found millions of dollars to rehire nurses. And that triggered him to do a report in which he found that $1.75 billion of taxpayer dollars had gone to executive pay at nonprofit hospital systems in the last decade. Comparatively, the nurses' salaries had only increased 14% over the last decade, an increase of 1.4%, where CEO pay had actually doubled in the last 5 years in nonprofit healthcare systems. So he became critically aware that there is plenty of money in healthcare, but it is all going to everybody but the front line of nurses. And as long as nurses remain the largest cost structure in healthcare systems, as they try, and then if you're a business person, you know this, right? You have costs and you have revenue, and you cut costs. You don't invest in costs. And that is what has historically been done to nurses throughout history. And everybody else generates revenue, PTs, OTs, surgeons, physicians, right? But all of that could literally be done outpatient. The truth is, The reason that you are in a hospital or nursing home today is your life is so at risk that without 24/7 care and monitoring by a nurse, you could die. And what we have done is, because nurses are rolled into the room rates, they are as valuable as the bed. You can actually argue that bedpans are actually more valuable to hospital systems because they have a reimbursement code. The reality is that we will always have this misalignment between staffing nurses to the level that provides safe patient care and also make a sustainable ability for us as nurses to practice safely at the bedside as a model that will always run into the direction of all that hidden cost and value of what we have nurses can be spent elsewhere. It can go to executive pay. It can go to building a new stadium. It can go to sponsoring a sports team, as opposed to paying for the nurses to keep patients alive. And that is what fundamentally is. And Constance, I am not coming up with one model. In fact, the commission agreed on this past week in our meeting, which we had over 1,300 people sign up. We now have 46 different states represented and we're activating. We're putting a call out actually to the general public to say, come to us with models that could work, in your opinion, to deal with this, because we know that it's worked for every other profession. We pulled occupational therapy, kitchen services, respiratory therapy, physical therapy, nurse practitioners, all out of the room rates in the last 4 decades. There are models that work. We know we can do this for nursing. The problem is we never knew why this had happened in the first place. And now that we do know, we know that we can change this and we must change this for sustainability going forward.
How does that really help to stabilize from where we are now into the future?
Yeah, so we know that the biggest profession at risk is the nursing profession. So what you may be aware of, let's talk about some statistics. We have over 5 million nurses in the United States when you add RNs and LPNs together. It's the largest profession of all professions in healthcare and all professions in the entire country. There is not a shortage of nurses in the United States. There's a shortage of nurses willing to work in healthcare environments as they are today because it is so unsafe to practice. So nurses are choosing not to practice because the ratios are too high, because the reimbursement for I think you may be aware, but nurses cap out on their earning potential at 20 years of experience. This doesn't happen to any other professional. In fact, nursing is the only hourly waged professional in all of healthcare that has a degreed program. So what we have made nurses is a simple cost to healthcare systems without a career path or an investable resource. So what's happening is nurses, so in those numbers, the average age of a nurse is 55 in this country. 70% is over the age of 40. But we turn out new grads at the rate of 175, 180,000 new grads a year in this country, an increase of nearly 250% from the early 2000s, according to research out of the University of Pennsylvania, by Linda Aiken. They are not staying. 57% of new grads left the bedside within 2 years of practice prior to the pandemic, which shows that a pandemic had nothing to do with it. We produce plenty of nurses, we don't retain them. And as long as nurses remain cost to healthcare systems, the environments in which they work will be unsustainable for nurses to continue. So by creating a reimbursement model, you allow hospitals to say, you know what? We know we need more nurses. And to do that, we can now charge for them so that we can afford to actually make our operating budgets work. Now, this came to proof and case. You may have heard about what happened in the state of Minnesota just a few months ago under Mayo. There was a bipartisan bill that passed their local state government all the way up by bipartisan support. Republicans and Democrats signed up, passed the House, it passed the Senate. It was called Keeping Nurses at the Bedside Act. It made it all the way to the governor's desk. And in the 11th hour, Mayor sent a note to the governor in which they wrote, if you sign this bill, Mayo will pull billions of dollars of investment from the state. And the reason they did this was this bill had proposed that you would have put together committees to help establish the number of nurses needed based on acuity level of patients in the hospital. Acuity level, just committees. It wasn't ratios, it was acuity level. And Mayo's argument was, we can't staff to acuity levels because 56% of all nurses in the state of Minnesota work part-time. So we can't meet those metrics. They knew full well that there is plenty of money to do this, but they blocked the ability for nurses to be staffed safely. And let's be very clear about one thing. All of the studies historically led by the NIH, the number one reason of increased mortality of patients is when you have poorly staffed ratio of nurses. We know that for every one increase in patient more than nurses over a certain level, you have a 7% increase of death and dying of a patient. Mm-hmm. And the truth is, we know this, hospitals know this, but they do not want to be told that the money should be going to nurses. But we do believe that if you pulled this out, and actually we have a whole bunch of hospital CFOs who are supporting the commission because they recognize this as the fundamental disconnect in their hospital systems. They know that every single day of every single month, their chief nursing officer looks at them and says, I need more nurses. And they say, we don't have more money to give you for nurses. You've already gone beyond what we can afford. So I think to that point, Constance, the future of healthcare is nursing services. And if we cannot stabilize the nursing profession to deliver care within our healthcare systems, fundamentally, healthcare will collapse in this country. Because the truth is we've never been able to replace the nurse at the bedside. And you know this as a nurse informaticist, we're dealing with technologies every day that are coming in that are saying this is going to decrease workloads on nurses. This is going to drive efficiency. This is going to make less work for the nurse. But actually, historically, in the course of the last decade, that has not happened at all. The more technology brought in has actually complicated things. It has not led to better outcomes for patients, and it certainly has not led to better work environments for nurses. So I think the question that I ponder when I talk to nurse informaticists is, what is the future role of nurse informaticists to stand at the future of the nursing workforce and define and design nursing environments or healthcare environments that will retain the nursing workforce and actually objectively and measurably measure the impact that technology is having on that workforce so that we can create it to be sustainable.
Well, I know that there are a lot of groups out there that are working toward these types of things and taking project by project, but I will say, Rebecca, that informaticists work in so many different ways. And it's just like the nursing profession, right? So the whole time I'm listening to you, I'm thinking to myself, what's this going to do? Circling back to the whole reimbursement model, what's this going to do with the programs that we actually have and the standards that we hold nurses to? We still have LPNs, we have BSNs, we have RNs, we have all of these different programs. Is this going to force us into a single model, or at the very least, just starting out at a baccalaureate level and then moving on from there? Like what's actually going to happen there? What are the unions thinking? Are they thinking about all of this reimbursement program? Because I would imagine they would have plenty to say about it. But you're absolutely right. Informaticists, basically what we did 20, 25 years ago was we took a sheet of paper and we programmed it to look like that piece of paper and we put it right in the computer, right? So There was nothing to say, this is automated, this is going to be easier. Because there were many, and I happen to have worked for a vendor for quite a long time until now. It just didn't make it easier. It was, you could make it whatever you wanted it to be. And every organization did just that. They made it what they wanted it to be. So there was still, again, no standard. Right. So no standard in the nursing profession, no standard in how we're actually documenting. And again, there are groups working on that too. So there's so many things that are swirling around right now. And the future of the informaticist, I would say, is absolutely a bright one, but we need to get it together, I think, and think about how technology truly is affecting the workforce. There are lots of programs out there. There's so many ways to think about all of this, but we certainly do need to come together and figure out how we're practicing and then how we're affecting our nurse colleagues at the bedside and in the doctor's offices for sure too, in the practices.
I think in all settings, let's be very honest, this is not a nursing shortage in just one specific setting. There's a national nursing shortage in all settings, from long-term care, home care, any environment that we're in. There's just not nurses practicing. We have overburdened the nursing workforce to a point that they're choosing to even become truck drivers before over being nursing. And this is a problem because we know we love our profession. We all would like to practice at the bedside if it was safe to do so. And I think the impact of the Redonda Vought trial has an impact on the collective psyche of our profession, where you are now at risk of criminal prosecution for a self-reported medical error that results in harm of the patient, has just fundamentally eroded our trust in our healthcare system and our ability to operate. No matter how much we love our profession, we're not going to risk our families and our livelihoods and our freedom when we go in with the best intentions and can actually be criminally prosecuted because harm is a result of a failed environment. And I think if I'm looking at informaticists, the truth is that informaticists are going to have to evolve to become data scientists. You're going to have to be able to translate the information into actionable results. And right now, much of what we've done as informaticists is we've swam in data lakes, and data lakes for the sake of data is simply not something that is of value. In the last 10 years, that's what we've done, right? We basically said, okay, here's the data, but of that data, there's so much of it, it is not actionable. So my advice to nurse informaticists everywhere is it's one thing to have data and to say that you have information on that, but if you can't translate that data into actionable directions, it's not worth dealing with, right? So my goal would be for the nurse informaticists to start looking at the strategic direction that the programs that data scientists are doing and are taking off. And let's be honest, are quickly swallowing the healthcare field. The data scientists are the ones where all the investment is now going into because they're processing the information that the informaticists are collecting and making all of the decisions, right? Now, we need the nurse informaticists to be collecting that information, processing it, and being the ones who make the decisions. And right now, what I'm feeling in the world of nurse informaticists is that they are just being given the products to collect this data, to collect these insights, but none of that responsibility or opportunity to actually change the direction of the business as it operates based on those findings. And that's why we have to evolve the nurse informatics profession. We need to be taking in new directions and owning those results and those actionable items in a way that the profession currently has not done or historically has not done. Because as to your point, much of what informaticists did was take a paper process, put it into a computer process, and call that an innovation that we could simply speed up for purposes of reimbursement. And that is unfortunate that that is where the goal has been historically for nurse informaticists, because the reality is that nurse informaticists could look at the nursing shortage and say, so tell me, Lemon, I'm looking at the workforce data. Why did 57% of new grads leave our facility within 2 years? Why is it that the average age or length of experience on a 12-hour shift was 6 years of experience prior to the pandemic within our setting, and now is at 2.7 years of experience on our hospital floor? What has happened, right? To me, that is the role that nurse informaticists can start gathering data and start really parsing out the impact that certain actions can have on changing the trajectory of the nursing workforce in all settings. And they should be the ones having the voice. I am so tired of going to healthcare conferences and webinars where everybody talks about the nursing workforce and not a single nurse is on stage presenting about that information, except at nursing conferences where nobody listens to us anyway when we leave those conferences. So my goal would also be is nursing informaticists start showing up at those conferences where those conversations are happening, not in nursing, and start driving forward your information to present there. Get a poster presentation, get a speaking one, go to Health Dive, all of these conferences where the decision maker sits, but not the voice of the nurse.
I can't agree enough with you there. And there is so much to dissect in what you just said, Rebecca, for sure. But I think too, I've been in a lot of organizations across the country. I've been associated with places that were really far along in their journey that had informaticists along the way. And then I've been within organizations that are really still in their infancy, or they completely just decimated the team. You know, I'm a lot of nurse informaticists went back to the bedside during the pandemic because they were there, or if they chose not to, they were home But how were they actually looking at the data? I mean, again, I think there's a lot of variation in the way that we practice and variation in the way that organizations individually see us. They individually see us as different things. So you walk into one organization and they may be the data nerds, right? They may be looking at the data and saying, hey, what about this? Where are we going from here? How are we staffing based on these numbers? Or are they still in implementation mode? Because when you're in implementation mode, that's all you can think about, and you're thinking about training and things like that. So there's a huge amount that we could dissect there, Rebecca. We could probably have 6 more podcasts.
It's true. And I think that the reality is, yes, I think one thing that we should all realize is in this cog and in this wheel, we are all commodities at any point in time within each direction of our career, right? And I think we fear that tremendously, that we could lose our job or we could, lose our role. And what I would say to nurses everywhere who fear that is do not let your job define who you are going to be or the passions that you're going to have. And I think we live our life often by fear of what would happen if I lost my job, as opposed to what would happen if my job changed. And the truth is every time that I've come into those moments of fear where things start to feel overwhelming, I've taken a jump or a leap of faith that has always gone higher. And I think that is something that we as nurses have been risk averse to. We've been risk averse because we don't know what we don't know, and we've been scared to try it. And what I would tell everybody that's listening to this is that the truth is that life is going to, you have 2 options. You can stay in environments that are going to make you feel unvalued, unheard, and unseen and settle in there. And that will be what life is. Or you can take the risk to say, I'm going to make something do. And you know what? The truth is it's going to be hard and it's going to be difficult, but you bet on yourself. And I think not enough of us do. And I think as nurses, we've all been in situations at the end of life with people. And what they have all said is, I wish I had taken more risks in my life or tried the thing that I was scared to do, because life is short. And the truth is that we're going to have many jobs in this life. We're going to have many jobs. We're only going to have one life. And the truth is, it really does work out. It really does. And I wish to tell you that I lived a golden life where everything that I wanted to have happen happens in my career, or that the rooms that I sit in with other executives hear me as a woman or as a nurse and translates that into action, but it is not. And I sometimes think to myself, a conversation I recently had with a family member, and they reminded me that imagine how far your grandmother's generation could get, and then how far your mother's generation could get, and then how far you've gotten. And why you need to keep fighting, because you hope that the next generation, the one that my daughter lives, means that there will be more seats at the table for nurses. There will be more seats at the table for women, and that we still have a long way to go. But it doesn't mean that we can't fight and that we should give up. So I think to all the nurse informaticists out there who feel beaten down, my advice is that you continue to network. You continue to be brave and bold. Don't speak less, speak more, and know that if you're willing to bet on yourself, in the end, there will find a way. I've seen it, and I believe it. And I watch those people. I've watched incredible people lose their jobs who went on to build the most successful organizations that their field has seen. And we just don't believe it can ever be us, but it absolutely can be.
Words of wisdom. Well, taken from someone who has been out there, Rebecca, you just shine. Keep fighting for all of the nurses, all of us out there. We really do appreciate you, and hopefully we'll be able to dive into some of the things that you're working on, and would love to have some links to those organizations so that we can read about what you're doing, and keep posting out on LinkedIn. We will certainly follow you, and we so appreciate you coming on the show today.
Well, Constance, thanks so much for having me. Everybody, keep up the good fight. The future of nursing is bright as long as we continue to define it. So thank you for having me.
Absolutely. Thank you, Rebecca. Thank you for joining us today. We hope you'll join us again for another session of Informatically Speaking.
This has been a production of the Greater Delaware Valley chapter of the American Nursing Informatics Association. For more information about the GDV Ania chapter, visit us at community.ania.org/Greater Delaware Valley/home.